Diffuse large B-cell lymphoma. It is the most common lymphoma in adults. It is aggressive in nature, and the cells of origin of this neoplasm are germinal center or post-germinal center B cells. The median age of occurrence of this neoplasm is 60 years, but it can occur at any age. It constitutes about 15% of childhood lymphomas. So now let's talk about the pathogenesis of this neoplasm. In 1/3 of the cases, we have rearrangements in BCL6 gene. We can also have activating point mutations in the BCL6 promoter. As a result of both of these aberrations, we have increased BCL6 protein levels. And we know that BCL6 is a transcription regulator, and its overexpression results in block in differentiation and increased uncontrolled cellular proliferation. In about 30% of the cases, we have 14-18 translocation. As a result of this translocation, the BCL2 gene moves near the IGH locus and overexpression of BCL2 occurs. We know BCL2 is an anti-apoptotic protein, and its overexpression results in increased cellular survival. In the remaining cases, we have diverse mutations such as translocation involving the MYC gene, and this MYC is involved in cell cycle as well as in the cell metabolism. Next, we have immunophenotype. These neoplastic cells, they have CD20 marker as well as CD10 marker, and this CD10 marker, we know that it is marker of germinal center B cells. We can also have IgM or IgD immunoglobulins. Now let's talk about the morphology. These neoplastic cells, they are 3 to 4 times larger than resting lymphocytes. The cell morphology, it varies from tumor to tumor. In most of the tumors, we have cells that have round to oval nuclear contours. They have dispersed chromatin and pale moderate amount of cytoplasm, several distinct nuclei that are peripherally placed. In some tumors, we have cells that have round or multilobate vesicular nucleus. They have 1 or 2 centrally placed nuclei, and they have abundant pale or basophilic cytoplasm. In some tumors, the cells, they are highly anaplastic, and tumor giant cells, they resemble Reed-Sternberg cells of Hodgkin lymphoma. We have 3 special subtypes of this neoplasm. Number 1, we have EBV-associated DLBL. It occurs mostly in AIDS patients, in patients with iatrogenic immunosuppression, like the kidney transplant patients, and in elderly patients. The second type is primary effusion lymphomas. It actually occurs because of a virus, that is Kaposi sarcoma herpes virus, KSHV virus, which is also known as human herpes virus 8, HHV8, and it arises in the cavities like pleural cavity, pericardium, or peritoneum. Here in this case also, most patients, they are immunosuppressed. Third type, we have mediastinal large B-cell lymphoma, and it occurs mostly in young females, and it spreads mostly to abdominal viscera and CNS. Next, we have the clinical features. This neoplasm, it is rapidly enlarging and symptomatic. It can occur at one site or several sites, and extranodal presentations, they are common. GIT is the most common site, but it can also occur in any tissue. Treatment, we have chemotherapy, anti-CD20, immunotherapy, and hematopoietic stem cell transplantations.